Hi, good morning, everyone. My name is Dr. Manisha Uppal, and I'll be giving a presentation on Restless Legs Syndrome, also known as Willis Ekbom disease, and I'll be covering the updated treatment guidelines as well. So just a historical, just a historical background into it. It was in 1672 when the earliest descriptions of restless leg syndrome was made by Sir Thomas Willis. And I'm just reading an excerpt out of that. He said that the diseased are no more able to sleep than if they were in a place of greatest torture. It was only in 1944 when Swedish neurologist Carl Axel Ekbom described 8 patients with what he called paresthetica, asthenia crurum paresthetica, and he described the salient features of the disease and coined the phrase restless legs to describe the patient's inability to lie still. He wrote, "The syndrome is so common and causes such suffering that it should be known to every physician." And keeping those words in mind, I'd like to start my presentation. So what is restless leg syndrome? It is characterized by an unpleasant or uncomfortable sensation in the legs and an irresistible urge to move them. Symptoms generally occur in the late afternoon or evening hours and are most severe at night. And they can also occur when someone is inactive or sitting for extended periods of time. It is consequently labeled both as a sleep disorder and as a movement disorder, although it can best be characterized as a neurological sensory disorder as the symptoms are produced from within the brain itself. The worldwide prevalence of this disease is around 3.9 to 14.3% in the general population. And in the US, this is around 7 to 10%, of which 1.5 to 2.7% have moderate to severe disease with symptoms lasting at least twice a week. It can occur in both men and women are being affected more than men, and it can begin at any age, although symptoms generally become more frequent and last longer with age. Etiologically, it is classified as primary or secondary. The idiopathic restless leg syndrome has been associated with certain genes which have been identified through genome-wide association studies, and I'll mention the specific alleles a little later in the presentation. Apart from that, low levels of iron in the brain also have been known to play a role, and it is familial in around 50% of patients, and in these patients, it generally occurs before the age of 40. RLS can also occur secondary to certain diseases like end-stage renal disease, hemodialysis, iron deficiency, pregnancy, neuropathy, and certain medications like anti-nausea medications like metoclopramide, antipsychotics like haloperidol and phenothiazine derivatives, and antidepressants that increase serotonin. Also, the older antihistaminics like diphenhydramine are also known to cause it. The key difference between the primary and the secondary restless leg syndrome is that the primary is generally slower to develop and it follows a more chronic course, whereas the secondary RLS generally has a more rapid progression of symptoms, and these generally remit when the underlying cause is eliminated. The classification based on clinical course is into intermittent, chronic persistent, and refractory RLS. Intermittent restless leg syndrome is defined as symptoms that occur less than twice on an average, but 5 or more times overall. Chronic persistent RLS is defined as symptoms that occur twice or more than twice in a week on an average and result in moderate to severe disease, with symptoms so frequent and troublesome that they can actually require daily treatment. Refractory RLS, on the other hand, is unresponsive to monotherapy with tolerable doses of first-line agents. And this unresponsiveness is generally due to a reduction in efficacy, augmentation, or other adverse effects of the disease or of the medication. And it's important to note that those patients who have never responded to the dopamine agonists cannot be classified as refractory RLS. They need to have shown some response earlier for us to call it refractory. The 3 major pathophysiological mechanisms that have been studied and understood up till date are the genetic, iron, and dopamine pathophysiology. The genetic pathophysiology is something that I covered initially too, and the 5 the risk alleles which are present on the 5 specific genomic regions are the ones that are given on the screen. And then the iron pathophysiology mainly concerns the central nervous system iron status. And the 2 major expected pathophysiological consequences of this reduced iron in the brain are hypoxia and myelin loss. So hypoxia basically occurs because oxygen transport depends on iron, and therefore a reduced iron leads to hypoxia, which in turn induces the hypoxic inducible factor 1 alpha, which is found to be increased in the substantia nigra of these patients, and the hypoxic inducible factor 2 alpha and the vascular endothelial growth factor, which are found to be increased in the microvessels. And activation of these hypoxic pathways in turn lead to an increased dopaminergic activity within the brain. Also, myelin loss occurs in response to the reduced brain iron, and that happens because myelin synthesis also is dependent on iron. But perhaps the most important pathophysiology and the one which serves as the basis behind the recent changed guidelines for chronic persistent RLS is the dopamine pathophysiology. And it's interesting to note that up until now, the first line agents that were being used in chronic persistent RLS were dopaminergic agents. And this was despite the fact that in RLS, there is an increased dopaminergic stimulation in the brain. This actually raises the question that how is it that increasing the dopamine further by levodopa reduces the symptoms when there is already an excessive dopaminergic stimulation in the brain? And to be able to answer this apparent contradiction, it's important to appreciate the circadian aspect of both the dopaminergic activity and the symptoms that occur in restless leg syndrome. So dopamine has a clear circadian activity. It reduces in the evening and night, and it increases in the morning. And in RLS patients, the increased dopamine stimulation in the brain results in a postsynaptic downregulation at both the receptor and internal cellular function levels. And this in turn leads to a generalized pattern of reduced T2 receptors. And while this postsynaptic adjustment to that increased dopamine stimulation, suffices for the daytime, it seems to overcompensate when the dopamine levels naturally fall during evening and night. And this in turn leads to a dopamine deficit in the evening and nighttime, despite an overall increase in dopamine in the disease. And this is what causes that circadian pattern of evening and night symptoms of RLS with, if anything, a short period of hyper-alertness and arousal in the morning, despite the short and disrupted sleep that these patients experience. And this mechanism is what was the reason behind the earlier guidelines, which stated that a small dose of dopamine in the evening and night can serve to correct the relative evening decrease in dopamine. And I'm sorry, not just the earlier guidelines, even till date, dopamine is used, but it's now a second line agent. And the reason why it has been used as a second line agent now is because the treatment with the increased dopamine stimulation has actually found to increase the downregulation beyond what is actually occurring with the disease, which worsens the underlying disease and augments the symptoms and requires even more stimulation at higher doses for the dopaminergic agents to actually be effective. And this initially can look like tolerance to the medication, but is actually a worsening of the underlying pathology and is labeled as augmentation. And I'll discuss augmentation in detail a little later in the presentation as well. The main conclusions that were drawn from this pathophysiological mechanism and understanding it was that dopamine needs to be used carefully at low doses in the evening or nighttime, that short-acting medications generally lead to a worsened augmentation, and longer-acting agents like the ruticotin patch reduces the risk and severity of augmentation, but can still produce it at higher doses, and therefore low doses need to be used. But the major caveat, of course, is that any of these dopamine medications will have a limited lifespan for effective treatment. And I covered this before too, but just to go over it, the description of the sensations that the RLS patients experience is they may describe it as a pulling, aching, throbbing, itching, or crawling sensation, or feeling like that of an electric current. The diagnosis, unfortunately, there's no specific test to diagnose a restless leg syndrome, but there are certain clinical criteria and, of course, a medical history, a complete physical and neurological exam, and certain blood tests can help support the diagnosis as well. The 5 essential criteria that need to be met are a strong and often overwhelming need or urge to move the legs that is associated with abnormal, unpleasant, or uncomfortable sensations. The urge to move the legs starts or gets worse during rest or inactivity. The urge to move the legs is at least temporarily and partially or totally relieved by movements. And the urge to move the legs starts or is aggravated in the evening or night. The recently added fifth criteria is that the above four features should not be due to any other medical or behavioral condition like arthritis, leg cramps, positional discomfort, or myalgia. And there are certain supportive criteria as well, like a positive family history, the presence of periodic limb movements, and a response to dopaminergic therapy. The medical history mainly focuses on understanding how the individual describes these symptoms and how they identify certain triggers and relieving factors. And another important thing would be the list of medications that the patient is currently on. A neurological and physical exam, as well as the lab tests, help exclude other diseases which may worsen or cause restless leg syndrome, and these include kidney failure, iron deficiency anemia, pregnancy, and diabetes. In fact, the prevalence of restless leg syndrome in diabetes in one of the studies was found to be as high as 28.6%, and another study found that it was the polyneuropathy in particular in diabetes that seemed to be the strongest risk factor in these patients. Apart from basic lab tests, a sleep study can be done to help identify other sleep disorders which may alter the management of the disorder, and for that reason it might be important to do. And most importantly, if we look at the periodic limb movements, periodic limb movements support the diagnosis of restless leg syndrome, although they do not give us a definite diagnosis. And to understand that, actually, we need to know the difference between restless leg syndrome and periodic limb movement syndrome. And there is an association between the two, and it has in fact been found that around 80% of the individuals with restless leg syndrome experience periodic limb movement syndrome as well. But only less than half of those with periodic limb movement syndrome have restless leg syndrome. And there is this very specific criteria for diagnosing PLMS, and that is involuntary rhythmic brief contractions characterized by involuntary leg and sometimes arm twitching or jerking movements during sleep that typically occur every 15 to 40 seconds and sometimes throughout the night. And and in this image at the bottom right, we can see that these are the periodic limb movements that can be seen on the polysomnogram. And this is an example of periodic limb movement disorder. And it is, of course, important to treat the restless leg syndrome in these patients as well, because that can help reduce the episodes of periodic limb movement as well. I'm sorry, I accidentally clicked on the link. I'm just going to go back to the presentation. And how is the severity assessed? There are three main validated scales that are currently in use: the International Restless Leg Scale, the Johns Hopkins Restless Leg Severity Scale, and the Restless Leg Syndrome 6 scale. The IRLS is the main scale that has been used as a benchmark outcome for treatment trials in RLS, and it consists of 10 questions that help the patients rate the severity of various parameters on a scale of 0 to 4. And this includes questions about the overall severity of the arm and leg discomfort, the severity of the need to move, the relief obtained by such activity, the number of hours a day and the number of days a week with symptoms, the severity of the sleep disturbance, as well as the subsequent tiredness, as well as the impact that these symptoms have on mood and quality of life. The total score is 40, and a score of 10 or below is characterized as mild RLS, 11 to 20 as moderate, 21 to 30 as severe, and more than 30 as very severe. And in general, mild RLS may cause a minor annoyance, whereas severe generally requires long-term treatment. The Johns Hopkins Restless Leg Severity Scale is a single item scale, which is used as a quick screening device, and it assigns the score based on the usual time of the day at which the symptoms occur. And the reason behind using the scale is that if the symptoms start, they generally persist until the morning. And so an earlier symptom onset will actually correlate with more severe RLS. And if you look at how the scores are given as well, that also corresponds with that, with 0 as no symptoms. And then if it occurs during bedtime, it is considered mild at a score of 1. And if it occurs in the evening or at 6 p.m., it's considered moderate with a score of 2, and then so on and so forth. The Restless Leg Syndrome 6 scale is the most recently validated scale which is used in RLS, and it's composed of 6 items with the scoring on a scale of 0 to 10. And this is not considered to be a replacement of the IRLS, but only as a supplement, as it gives us additional information, not just about the levels of satisfaction of sleep, but also it rates the severity of the symptoms in the last 7 days under 4 separate specific circumstances, like while falling asleep, during the night, during the day while sitting or lying, and during the day when moving around. There are some other questionnaires that are used to assess the quality of life in these patients, which include the Epworth Sleepiness Scale, which assesses the likelihood of falling asleep in 8 everyday situations and can help identify excessive daytime sleepiness. And also the Hopkins Restless Legs Syndrome Quality of Life Questionnaire, which assesses the impact that it can have on daily life, emotional well-being, social life, and work life of these patients. And the CGI-I, which is the Clinical Global Impression Improvement Index. I'm sorry, there's a typo there. Apart from this, now I'd like to discuss the management, and in particular, the major changes that have been made in the recent guidelines with regard to the management of restless leg syndrome. So the 3 main changes are that we now understand the role of iron therapy a little more, in particular, how intravenous iron can be used in the treatment of these patients. The approach to chronic persistent restless leg syndrome has changed. As I said before, dopaminergic agonists are no longer first-line agents. Rather, it's the alpha-2 delta ligands, which are first-line agents, and dopamine agonists are second-line agents. And there is also an update on the use of opioids, which are generally indicated for the management of refractory restless leg syndrome, with, of course, all the appropriate precautions for opioids. Some general considerations that need to be made for all patients of RLS is that the iron status needs to be assessed, and oral or IV therapy of iron needs to be considered based on those results. Also, you need to assess for other sleep disorders, as concurrent sleep disorders often exacerbate the condition, and treatment of these, for example, treatment of sleep apnea, can help improve the symptoms of RLS as well. Apart from that, RLS is also associated with certain mood disorders, with depression, anxiety, and with intake of medications, caffeine, alcohol. And that needs to be addressed as well. So moving on to how the iron therapy is actually administered. So as I said, all patients need to have their iron levels checked, which would include a full iron panel with the total serum iron, serum ferritin, transferrin, saturation. And all patients who have a ferritin concentration of 75 or below micrograms per liter and a transferrin saturation of less than 45 should receive a trial of oral iron therapy. There are some considerations that need to be made in this, is that not all patients should be prescribed iron empirically, because you could have unsuspected hemochromatosis and you do not want to cause an iron overload in these patients. Also, if the serum ferritin level is below what is considered normal for the patient's age and sex, then you do have to consider that they might be iron deficient as well, and it could be unrelated to the RLS. And also in acute chronic inflammation or malignant disease, there is a lower cutoff for transferrin saturation for less than 20%. This is because these diseases lead to an increased serum ferritin, and that can actually remain elevated for up to 6 weeks after the disease. And so the cutoff is slightly lower for them. Iron therapy is generally given as a 325 milligrams of ferrous sulfate with 100 to 200 vitamin C supplement every day or every other day. It's ideally given on an empty stomach, and specifically studies have found that giving iron at night seems to increase the iron in the brain more effectively, and so it's preferable to give it at night. The follow-up for iron is that initially the first reassessment is done at the 3 to 4 month mark, and then it is done every 3 to 6 months till the time the serum ferritin level reaches 100 or above. And if there is no ongoing cause for iron deficiency and it reaches a serum ferritin level of 100, then oral iron therapy can be stopped. But if the symptoms worsen, then we can restart it up and bring the serum ferritin up till a level of 300 if required. And when is intravenous iron indicated? This is indicated when the serum ferritin is below 100 in the absence of any inflammation, and when the transferrin saturation is less than a 45. It also can be considered as the first-line iron therapy in moderate to severe chronic persistent or refractory restless leg syndrome, when the serum ferritin is between a 76 or 100, or when a more rapid response is desired than is possible with the oral iron. Apart from this, of course, if they fail the oral iron therapy, which is a 3-month trial, or if it's not tolerated, or if it's not absorbed properly because of some gastrointestinal disorder or bariatric surgery, then IV iron would also be considered. Currently, all of the formulations are FDA approved, although the most commonly used one is ferric carboxymaltose. And apart from this, low molecular weight iron dextran and furomoxetil can also be used. They're usually given as a 1,000 milligram single dose or 2 doses of 500 milligrams, 5 to 7 days apart. The response may take a while, up to 4 to 6 weeks. And if an adequate response is not found even then a transfusion can be repeated, but this needs to be at least 12 weeks apart. And the serum ferritin, concentration needs to be less than 300, and the transferrin saturation needs to be less than 45 for us to consider a reinfusion. The side effects with IV ferric carboxymaltose is hypophosphatemia is seen in around 39% of patients, which may contribute to osteopenia. Now moving on to the specific types, intermittent, chronic, and refractory RLS, and how each of these are managed. So in intermittent RLS, we first start with non-pharmacological therapy, and intermittent medications can also be helpful in patients who are not responding to this. And the non-pharmacological therapy mainly involves determining the patient's iron status and treating it accordingly, identifying any sleep disorders that coexist and treating those, any medications that may be exacerbating them, and stopping them if that is possible, and to try stopping caffeine and alcohol, and trying other mental alerting activities like crossword puzzles, etc., during periods of boredom. The intermittent medications that are used include carbidopa, levodopa, low-potency opioids, and benzodiazepines. The carbidopa, levodopa can be given in a dose of 25 or 100 milligrams, or in controlled release forms in the same dosage. And it is advised to give levodopa only for intermittent use, such as 3 weeks or fewer in a week, because of the risk of augmentation, which again, I will discuss a little later in the presentation. Another side effect of dopaminergic agonists is rebound in the early morning, which occurs in up to 20 to 35% of patients that take this medication. Another medicine that can be used are low potency opioids, such as codeine or tramadol. And these are usually given before bed or during nighttime. And some of the doses that are used are 30 to 90 milligrams of codeine in combination with acetaminophen, or 50 to 100 milligrams of tramadol, which can be taken before bed. Side effects include constipation or nausea. And tramadol, interestingly, is the only non-dopaminergic non-dopaminergic drug that can occasionally cause augmentation, apart from its rare side effect of causing seizures. And the third drug that can be used in intermittent RLS are benzodiazepines. And this is especially helpful for patients who have poor sleep for other reasons as well. For example, RLS can cause sleep onset insomnia, and for that, short-acting benzodiazepines like zolpidem at a dose of 5 to 10 milligrams or zaleplon at a dose of 5 to 10 milligrams can be used. And the disease can also awaken the patient later in night, and for that, intermediate acting agents like temazepam at a dose of 15 to 30 milligrams or isopicolone at 1 to 3 milligrams can also be helpful. In general, like as always with benzodiazepines, lower doses should be used in women and in older patients, and side effects include risk of falls, cognitive difficulties, especially in the elderly, and zolpidem is associated with sleepwalking and sleep-related eating disorder. Moving on to the chronic persistent, and this intermittent RLS, the treatment has more or less been the same, with some more clarity on the use of intravenous iron. But in chronic persistent restless leg syndrome, and I know I've said this twice before as well, but the first-line drugs are now alpha-2 delta calcium channel ligands like gabapentin, pregabalin, or gabapentin inacarbel, which is a prodrug, and these are usually given once or twice daily in the late afternoon or evening or before sleep, and it's preferable to give them 1 to 2 hours before when the patient usually gets the symptoms. Gabapentin is usually started at a dose of 300 milligrams, 100 in the case of patients who are older than 65 years. It is increased every few days to a maximum of 3,600, although the most commonly used dose is 1,200 to 800 milligrams daily. Pregabalin is generally started at a dose of 75 milligrams, 50 in case of patients older than 65. I'm sorry, there are typos here. And most commonly, it is used at a dose of 150 to 450 milligrams daily. Gabapentin inert carbil is actually preferred because it's a prodrug which does not follow the nonlinear pharmacokinetics that gabapentin does, and therefore it shows less inter-individual variability. And this is because the drug works after it has been absorbed, and it can be used as a single daily dose of 600 milligrams, 300 in case of patients older than 65 years. It is generally given at 5 p.m. and the most commonly used dose is 1200 milligrams. Apart from these alpha-2 delta ligands, dopamine agonists like pramipexole, ropinirole, and ruticotin patches can be used. Non-ergot agents are generally preferred because the ergot agents are associated with cardiac valvular fibrosis and other fibrotic reactions. Pramipexole is generally started at a dose of 0.125 milligram daily and is taken 2 hours before major RLS symptoms start. The dose is then increased every 2 to 3 days by 0.125 milligram until the time that relief is obtained. And it's taken up to a maximum of 0.5 milligrams in most patients. Ropinirole is started at a slightly higher dose of 0.25 to 0.5 milligram. It's taken 1.5 hours before the major symptoms start, increased every 2 to 3 days by 0.25 to 0.5 milligram, and taken up to 4 milligrams maximum, with 2 milligrams or less being the most common dose. The ruticotin patch can be applied once daily. It's generally started at 1 milligram and increased to 2 to 3 milligrams if necessary. There are some side effects like nausea and lightheadedness. It can cause application site reactions. It can, at higher doses, lead to daytime sleepiness. And apart from that, there are some less frequent side effects like nasal stuffiness, constipation, insomnia, and leg edema, which generally reverse on stopping the treatment. Follow-up for dopaminergic agents is important because we need to look out for the 2 major adverse effects of augmentation and impulse control disorders. And this is initially done every 3 months. And then once the patients stabilize, they can be reassessed at least once a year. Why are dopamine agonists no longer used as first-line agents? This is mainly because of the 2 major side effects that they cause, which is disease augmentation and impulse control disorder. Augmentation, there are certain clues which are almost completely indicative of augmentation versus tolerance to the medication. And these are that the onset of the symptoms occur earlier in the day after an evening dose of medication. There is spread of symptoms to the arms. There is paradoxical worsening of symptoms with an increase in the dose. And there's a shorter effect of each dose of medication. For pramipexole and ropinirole, this is seen in around 40 to 70% of the patients during the 10-year period, or at an annual rate of 8% per year for at least the first 8 years of use. And for the ruticotin patch, this is seen in around 36% patients after 5 years. The impulse control disorder occurrence rate is between 6 to 17%, and it can manifest as pathological gambling, impulsive shopping, or hypersexuality. And it commences on average 9 months after introduction of the drug. So how is disease augmentation, which is one of the major side effects of these dopaminergic agonists, how is this managed? This can be done in 2 ways. We can either reduce the initial drug and discontinue it with a drug holiday before a new agent is introduced. And anecdotally, what I found from case reports, the washout period is usually 6 weeks. And then another strategy could be that the initial drug can be reduced slowly after the new agent is introduced with an overlap period between the 2 medications. And to note that the rate of reduction should not exceed 0.25 for pramipexole or 0.5 milligrams for ropinirole every 3 days. Also, the second strategy is preferred for patients in whom abrupt discontinuation can cause severe RLS, sleep disturbance, insomnia, and depression, which usually is seen with patients who are taking higher doses of these dopaminergic agonists. Refractory RLS. So the initial treatment, of course, is similar to intermittent and chronic persistent RLS, that we check the iron stores, replenish it if required, correct any possible exacerbating factors, try combination therapy of all the drugs discussed so far. And most recently, opioid monotherapy has been given more importance. And it's important to note that this is very effective and that it should not be withheld from appropriately screened patients because of a fear of potential development development of tolerance or dependence. Of course, all the precautions need to be made. You need to assess for risk factors for opioid use, any personal or family history of substance use disorders. An opioid contract needs to be entered into where information about the drug adverse effects need to be given. There needs to be a follow-up visit every 3 to 6 months, and the patients should be counseled about how they should receive the opioids only from a single provider, and the dose should not be altered without their permission. Also, routine urine drug screens should be done at the start and then annually, and the state prescription drug monitoring databases should be regularly reviewed. These opioids are generally used at low doses, and the choice of drug would depend on the physician preference, the patient factors, and cost. Initially, usually short-acting agents are given, and then later on they're switched to longer-acting or extended release formulations. And I have a chart here with some of the commonly used drug dosages, and side effects I briefly touched upon before too include nausea, constipation, urinary retention, daytime drowsiness, cognitive dysfunction, unsteadiness, especially at night. And importantly, it can induce central sleep apnea and can also precipitate or worsen the obstructive sleep apnea. And therefore, in refractory restless leg syndrome, it is actually recommended that we check for sleep apnea or make sure that the patient does not have any sleep disordered breathing, as that could possibly worsen the RLS symptoms. Apart from this, low mood, increased sweating, and sexual dysfunction, as well as secondary adrenal insufficiency, may arise from opioid use. So this was the treatment so far, and what are the potential therapies that are currently under investigation for RLS? There are certain mechanical devices, and there was a trial which showed some support for the use of pneumatic compression devices, but there is still limited evidence for that. Vibration devices were shown to enhance the quality of sleep, but unfortunately did not improve the symptoms in RLS. Certain electrical and magnetic stimulation, in particular the spinal cord stimulation by implanted electrodes, was found to be found to show partial benefit in patients with chronic pain, in addition to RLS. And then the transcutaneous spinal cord stimulation with direct current showed some improvement in RLS symptoms in one series as well. Cannabis is something that has been extensively studied and whether it would be effective in the treatment of RLS. And a case series from a single center and patient anecdotes suggest that there possibly could be some benefit, but it's still unclear what formulation or what dosage and what mode of administration could actually be helpful. And there are a couple of things that need to be kept in mind, like cannabis can interact with the drugs that are being used to treat restless leg syndrome, including the dopamine agonists, alpha-2 delta ligands, and benzodiazepines. And also it can be harmful in patients with lung disorders. So more, I think, studies would be needed in this field to understand the effect of cannabis and the potential benefits of cannabis and in what dose it can be used in restless leg syndrome. The disease has a significant impact on the quality of people, and those who have untreated moderate to severe restless leg syndrome can actually, in around 20%, there is a reduction in work productivity. It can contribute to depression and anxiety. It can make traveling difficult. It can cause exhaustion and daytime sleepiness. It can affect their mood, concentration, job, school performance, personal relationships. And it can impair memory, and it can also lead them to fail to accomplish their daily tasks. So where can patients find support? There's the Restless Leg Syndrome Foundation in particular has a very extensive list of support groups that are available. And I think, yeah, I've put a link to that in this presentation as well. And they also have a free downloadable symptom diary, which is one of the resources that patients with RLS can use. Apart from that, there is the Johns Hopkins Center for Restless Leg Syndrome, and there's a link to their website here as well. And there's this Patients Like Me community, which doesn't just actually help patients with restless leg syndrome, but with any chronic illness. It's like an online community where patients, doctors, and organizations, they work together and they share disease information, and they can directly discuss their cases with each other. And I think this is a useful resource for patients who suffer from this disease. There are also certain books, and I've put the links to that in this presentation as well. And I think, yeah, that is it. Thank you. Thank you for giving me your time today.